else.
Okay. So there's the nodule within the right middle zone that I saw on the chest.
This one?
Yeah.
So you found two nodules, different size.
Yeah.
What do you want to ask?
Is there an abdominal is the history of previous malignancy?
No, there isn't. So how do you want to approach these nodules?
Is there an abdo-pelvis that I can look to see if there's another primary elsewhere?
Okay, so you want to exclude a hidden primary somewhere?
Yes.
Okay, let's assume there isn't any. I think we've done a PET scan, and there wasn't anything. I can. Yeah, there wasn't anything. So if it's an isolated abnormality, what do you want to call it? What do you want to do to it?
I want to biopsy it because the patient's symptomatic and we don't have a definitive diagnosis.
Yeah.
Probably suggests that the left opacity, the left nodule is a target for biopsy, CD biopsy.
So you're suspecting a lung primary, yeah? So you haven't said that word so far, primary lung malignancy. If it wasn't a lung primary, your first thought was metastatic from extrathoracic malignancy because they're bilateral. If there's no known, you're suspecting a lung primary. If they're both, either they're both primaries or one of them is a primary and the other is the MET, or he has something in the head, or it's a melanoma or something weird and wonderful. So, like I said, we'll come back to it at the end. I will give you a third one. I think we can squeeze in one more. Yeah.
So this is a AP chest radiograph of an adult. You can see that there is a increased opacity within the superior mediastinum, suggestive of an anterior mediastinal mass.
Why anterior?
Because I can see lung markings through it, so it's not in the middle mediastinum, and there's the silhouette sign between it and structures in the posterior mediastinum. So by exclusion, I would say that this is in the anterior mediastinum. Just finishing up my reviews, don't see any pneumothorax, no lower bowel collapse, no pleural effusion, nothing below the diaphragm. I don't see any destructive bony lesions. So, what's the history?
History is weight loss and night sweats.
How old is the patient?
45.
Okay, so in a patient with weight loss and night sweats, 45 years old, I think my top differential for these appearances would be lymphoma. Other differentials, which are less likely, would include thymic malignancy.
What else?
Teratoma, that's another anterior mediastinal mass. But I think the age.
Anything else?
Could be a thyroid.
Yeah. So these are the CT images from the PET. I don't have a contrast CT for some reason. So it, yeah.
Yeah, so there is an anterior mediastinal mass. It looks homogeneous, and I can see that it's showing intense avidity. Next steps would be a biopsy to confirm diagnosis of lymphoma, which is what this is most likely to be.
Okay. Okay, so let's go back. Let's do this one first because while we're fresh on it,
Yeah.
do you mind me asking if you work in the NHS in the UK?
Yeah, I do work in the so.
Okay, so let me bring up the first one, and I'll pretend I'm you. So I'm trying to figure out the X-ray while I'm doing it, and I'll tell you how to approach it as you're thinking, because that's the first problem we have is straight away we don't know what it is and we're thinking and we're speaking at the same time because we don't want that awkward silence. And it's very important to say what we're thinking, because that thinking process, if it's correct, even if your diagnosis is wrong, gets you a pass. So if you describe what you see appropriately and you're thinking in a logical manner, even if you get to the wrong answer, it's still a pass, rather than saying, magically the right diagnosis, but your approach was all wrong. Nobody's going to pass you for that. So this first one, you saw that straight away. You saw there was something in it straight away. You got distracted by this. This is exactly why I put that on. It happens every single time. And the elephant in the room you missed. So it was, but I had to nudge you to get there. So every time you get a nudge, you lose marks. But as long as you get there in the end, it's still a pass. So once you've picked a central increased density, the first thought is it just a hiatal hernia? Yeah, but you can see that the density is higher here than it is here. So there's something going on here. So once you've picked that, you need to think if it's a tumor or something in the middle, it would be causing something. So I'm going to look here, there, all sides, and then you would see this triangle. Yeah, it's a typical appearance of a central mass causing a peripheral collapse. If I didn't have this, it would be a better X-ray. Sometimes I put this up like that just to see if they can pick it, but then it's a very big hint that I'm trying to show something here. So while you're thinking, ways to buy time is to get the history out. And you said, I don't know what the history is. Yeah, but you didn't ask for it. You have to ask for it for me to give you the history. Sometimes, and it's a tricky case, we would offer the history straight away to guide your thinking down a certain track. But if it's a straight away, malignancy, we want you to ask for the history because the case is simple. You need to approach it the right way. So, for example, if it's on your reporting file, you pick it. If you miss it, it is an unacceptable miss. Yeah, even without the nodule in the left lower lobe, you have to pick that cancer. And unfortunately, the one lung cancer that we will all miss more than once in our reporting life is lung cancer, and it will be on a chest X-ray for exactly the same reason. Incidental lung cancers are picked way more than cancers from 2-week wait pathways because of how much there is and how late they present. So when I want you to approach a chest X-ray, I want you to pick all the abnormalities and start defining them. Because in the mediastinal one, you knew all the answers, but I had to ask you why for you to offer that information. You have to give me those points that you're checking through in your mind, because I don't know what's in your mind. I don't know what you know till you say it. So if I have to ask you why, you've already lost a mark. You need to explain your thinking while you're thinking it, because we don't realize, we think that it's rambling on, but it's actually giving a very lot of insight into your thought process. So if you're describing that, you would say, I'm looking at the nodule in the left lower lobe. I am wondering whether this is indeed inside the lung, or whether it lies in the breast tissue or the chest wall. I would like to zoom up into it. So every time you do something, explain what you're doing it and why you're doing it. It makes you sound a lot, not just smarter, but it gets you points because you're thinking the right way. In the end, if you didn't get the mark, you didn't get the diagnosis, and you would still get enough points to pass. So you're then thinking, I'm looking at the increased density in the middle of the mediastinum. There is no appreciable hiatal hernia lower down, so I'm wondering whether this represents a central mass. This triangular opacity adjacent to the heart is suspicious for peripheral atelectasis. I would like to do further imaging of this patient to assess things further. I am suspicious of underlying malignancy. I would like to know more about the history of the case. And then you pause, and then they say something like fever or something, then it's infection. Then they say something smoker, hemoptysis, and you say, given the history, I would be suspicious for malignancy. And if it's something this big, this sinister looking, if it's cancer, it is a very advanced cancer. So you can't just do a CT chest. You want the whole staging.
Mhm.
We do plain chests, only chests, when it's just a nodule, like the next one. If it was just a nodule, it could have been, in many cases, an overcall. Those are the ones we do CT chests for, is when we're trying to confirm there is something there. This one, we want to, escalate. So we do the whole staging CT. So that's one thing to remember. If you're suspecting something aggressive, go for a full staging CT just to show that you are concerned for very sinister pathology and you want to do that. Once you've done that, you have to say, I would highlight the report to the referring clinician. For urgent referral to the lung cancer pathway. The patient needs further cross-sectional imaging, and then they will show you the cross-sectional imaging, and then you would say, you would ideally like to stage it. You would refer it to the MDT. You have to say MDT. You have to be safe. You have to make sure we highlight urgent reports to the referrer, because these are the safety points that they're checking. Does that make sense?
Yes.
Yeah.
So the left lobe mass, is that not related to the?
It is. It's a MET from the primary on the right. I'll show you the CT. Because you had said consolidation, and I paused there. So a consolidation wouldn't give that bulge to the fissure. Consolidation would be flat. This is consolidation. You see the junk in the airways and the air bronchograms. But you go higher up, that hypo dense thing sitting there with that bulge, that's tumor. Consolidation doesn't do that to the bronchus. The bronchus is compressed, invaded, and then it's gone. This is all occluded bronchus with the tumor. All of this is tumor. And the contralateral one, this one is the MET. So this tumor, when possible, we want to access tumors endobronchially, and this one is a prime example. This can actually be debulked. So when you say this, if this was actually benign, this patient still needs a bronchoscopy because there's something occluding that bronchus causing collapse. So they need bronchoscopy regardless. But in this case, you would say, I see compression of the airways with occlusion causing distal collapse. The patient needs endobronchial sampling and wash to a certain underlying diagnosis. But that's the primary, and this one is the MET. Okay.
Yeah, thank you.
Once you call that a primary, you then have to say nodes. For central lung masses, you have to look at the SVC because those are your urgent life-threatening findings. Lung cancer, you have to look for the Brownie points, the incidental PE, the SVC obstruction, intracardiac metastases. Those are the ones that will get you the maximum marks. Because once you on a CT like that, picking an abnormality isn't exceptional. It's getting all the things right, and there will always be little things on the case that will take you that extra mile to get you full marks. I'll take you to the second one we did, which was the small nodule. I think you did really well here. You picked the nodule straight away, which isn't always easy. So that was a good pick. Again, the breast implants, a very common mistake, but in this one, at least you can clearly see the outline of the breast implants. This was a nodule. I think this was picked originally as well on the thing, but the CT gets confusing because the nodule's on the right. So that's the nodule you're looking at. And this, you didn't even see on this X-ray. Even if you go back, I still can't see it. So the bigger cancer was actually hidden. And that's here again, you said all the right things, but you didn't say them in order. And I think that was more nerves. So if you say solid nodule, spiculated margins, then you have to say, what is it doing around you? You have to say tethering of the pleura, suggesting of malignant pathology. Then you have to say no cavitation, no calcification, blah, blah, which all of those things you did, but they went in a haphazard pattern. But I think this was a strong pass, this case. And the last one also, I think you didn't get all the points you should have gotten because you knew it. You didn't want to offer that information for some reason. So mediastinal mass, they want all those fancy signs. They want you to explain why it is where you think it is. Even if you call this posterior mediastinum, for some reason, but you gave your thinking about why you think it's superior mediastinum, it can possibly still take you to a pass. But this one, you said widening of the superior mediastinum. You did not say it was smooth contours. You did not say it extended up into the cervix or the cervical region or not. You did not offer the silhouette sign. You didn't talk about the aorta till the end. But you got it right, but you didn't maximize your marks for some reason, even though the knowledge was all there. Mm-hmm. When you've picked a superior mediastinal mass, you have to say all the terrible T's.
Yeah.
This, I think, actually turned out to be thymic, but you have to say all of them, and you have to say calcification, no calcification, cavitation, no cavitation, because that's what changes the differential for them, especially when they offer you the CT, because they're not showing you the CT to confirm your diagnosis. They want you to say, I don't see any calcification in it. I see some low attenuation within it, suggestive of a degree of necrosis. I am following it upwards. It does not seem to communicate with the thyroid, things like that narrow down your differential a bit more. So after the CT, you would say it doesn't communicate with the thyroid. So I am excluding thyroid and leaving me with lymphoma and thymic, etc. as the more plausible differential diagnosis the patient needs. Again, the report needs highlighting to the referrer. On the X-ray, you need to do CT, you need to highlight to the MDT, and for consideration of biopsy. Did you want to ask me anything before I move on to the next candidate?
Sorry, what was the thing you said about on the chest radiograph, how to maximize the points? So how do you said something about the apex?
This one? Yeah.
What was that again?
Yeah.
Sorry?
It was for posterior mediastinum. You usually see them tracking up. Yeah. So this one is very lucent here. Then you said you didn't say smooth margins. If it's in the lung, not in the mediastinum, the margins aren't that smooth. This is quite smooth. The density is soft tissue, but there is no calcification. Those are the kind of points you needed to talk about. The margins. You needed to talk about how it extends or doesn't extend up. You needed to talk about whether you can see the paravertebral lines or not. You needed to talk about whether you see bone destruction of the vertebra or not. It could easily be a schwannoma. It could easily be an expansile sternal lesion. You didn't talk about those things. So yeah, that's what I meant with maximizing.
Yeah. Thank you, Dr. Rosa. That was really helpful.
Thank you. Okay. Do we have candidate number 2?
Good evening, Dr. Samavia. Can you hear me well?
Hi. You ready to start?
Yes. Can you hear me well?
Sorry?
Can you hear
yes,
me well?
Yes, I can. Yeah, I can. Yeah. So let me bring up your first case. Okay. Can you see the screen?
Yes.
Okay, have a go.
I am presenting with plain X-ray front view of the abdomen. From the first instant, I can pick two abnormalities. The first thing is bilateral hip prosthesis. The second one is dilatation of the bowel. I can see that the bowel is dilated at the center of the abdomen, center of the abdomen, and on the right side of the colon. However, I cannot detect any gases within the rectum. I cannot detect free air in the abdomen. I cannot detect any hernia or feces. However, in the left side, there may be a bit translucency here. I would like to scan the rest of the view. By returning to the two main abnormalities, I'm dealing with intestinal dilatation. This not likely to be large bowel dilatation with no signs of perforation and bilateral hip prosthesis. In my routine practice, I would like to review the history of the patient to see if there is any history of ulcerative colitis, any history of indication of steroid therapy. And I would like to gently communicate the finding with the referring physician and recommend further evaluation with contrast enhanced CT or SAT.
So the patient does not have ulcerative colitis, and the patient is not on steroids. He's not immunocompromised. The patient has abdominal pain for 4 to 5 hours.
Yes.
You said you wanted to do a CT?
Yes, contrast enhanced CT, yes.
To look for?
To assess the cause of the intestinal obstruction.
Why do you think there's an intestinal obstruction?
I can see that there is dilatation of the bowel. There may be obstruction. I can see that there is interruption of the air within the distal colon. So this may be due to bowel dilatation, and I would like to evaluate the cause of this dilatation.
Okay, before I give you the CT, the examiner would likely push you a little harder on the X-ray before they give you the CT to get a more specific diagnosis out of you. So you said there is dilatation of the large bowel. Any specific part of the large bowel that is dilated?
This may be cecal or the right colon level because I can't detect any corresponding dilatation in the left bowel. And there is dilatation in the right bowel. So I'm after here the level of obstruction can be on the level of the right colon.
So level of cecum. You think this dilated loop is cecum?
Which one?
This one, this big one.
No.
Or this one?
This one may be the right colon.
Okay. So if the right colon is dilated, would the obstruction be distal to the right colon or proximal?
If the right colon is dilated, so the obstruction would be on the level distal to this set of obstruction.
Yeah. So the dilatation would be proximal or distal to the level of obstruction?
Obstruction is distal to the level of dilatation. Obstruction is behind the dilatation.
Yeah. So if you think that's the right, I agree that's the right ascending colon, and then where does it go? And you said there's no gas in the rectum, so I'm guessing this little foci of gas.
Maybe the large, the distended bowel in the center of the abdomen corresponds to the transverse colon, because I can see, I don't know if you can see my pointer or not, but I can see it approaching the course of the left of the transverse colon and traversing in the left paraspinal region. This may be corresponding dilatation in the right colon and in the transverse colon too.
Okay. So I'll move on to the CT and then I'll come back to the X-ray to explain what. You want the soft tissue, this window, or do you want the, which window would you like?
Okay, I will start with the soft tissue window, then I may modulate it. Yes, okay. I may modulate it. You will take the control by yourself, or can I take the control?
I don't think you can take the control for some reason.
Okay, yeah. Okay.
Let me play with it.
I am providing with contrast enhanced CT of the abdomen. From the first instant, I can see that there is dilatation in the colon, in the level corresponding to the X-ray. I'm trying to approaching the level of obstruction and to confirm the cause. You can see that the distal bowel, again the left colon is here. I can see that there is interruption of the dilatation. There is an area of narrowing in the bowel. It's a little too rapid. Okay.
Okay, let's go back to the abdominal X-ray. So
Yes.
I'll point to specific loops, and I want you to guess which one they are. This is what colon is this?
Right.
Right ascending colon, yeah.
Yes.
So this loop that's a bit transverse. This one that's going that way. What is that?
I think this can be the distal ileum, or yes, this is the distal ileum.
So how would you differentiate small bowel from large bowel?
Small bowel is more in central location, with the pattern is it has valvular convergence, and the colon has haustration and more peripheral bowel.
So is this
But
illustration?
Sorry?
This one? Do you think you see the same pattern that you see in the central loop as well as this one? If I was to say this is the ascending colon, then it dips down, and this is the transverse, and then this is the descending. What is this structure then?
You mean the central one, which is
The central U-shaped inverted
yes.
U is what?
Yes, this may be due to sigmoid, may be sigmoid obstruction, sigmoid volvulus.
Okay, so what would a sigmoid volvulus look like? Does it check all the? Describe a sigmoid volvulus. What it typically looks like.
Inverted U shaped, coffee bean appearance, introduction of the bowel in the rectum with pelvic convergence sign. This is the signs of sigmoid volvulus.
Okay, so I would ask again that you follow the rectum up. This is the descending going up, ascending going down. So the transverse. So all this feces filled
Yes.
is the large bowel, and then there's this loop, dilated loop that goes all the way up, turns on itself, goes all the way down. Does that confirm your sigmoid volvulus?
I just want to see the coronal to confirm.
Okay.
I can see that there is dilatation in the colon in inverted U shape. Yes, this can be due to sigmoid volvulus. However, I cannot detect the convergence sign in the pelvis because there is a lot of fecal matter in the overlying bowel loops.
Okay, understandable. Let's move on to the next one. Okay, have a go at this one. This patient is extremely unwell. Let's just say that, as you can tell by the recess.
Yes, I am presented with plain X-ray of unwell patient, skeletal mature of the patient. From the first look, I can see that there are two opacities seen in both lung fields. The large one is seen on the right lung field in the mid-zone level. I can not see any cavitation within. The other one is seen in the left lung field in lower zonal and more peripheral distribution. I cannot detect any gas in the lower recess, no pneumothorax. So I am dealing here with a case of bilateral lung opacities. The differential diagnosis of such distribution and sign and appearance can include airspace disease. One possibility may be lung pulmonary edema. However, the typical bat-wing appearance isn't presented here. This can be multifocal pneumonic changes. This can be pulmonary hemorrhage if the patient has history of collagen disease or abnormality in bleeding tendency, like abnormality like bleeding tendency. So I would like to review the clinical history of the patient and see if there is previous X-rays was done to compare the course of the disease. I would like to communicate the finding with the referring physician and ask for further CT for more characterization.
So you mentioned bilateral lesions, and you meant this one, and you meant this one?
I can't, I don't know if you can see my pointer, but there is a large one on the right, yes, and another one in the left hemisthorax, in more peripheral distribution, and more in the lower zone.
Okay. Okay. So I want you to describe these abnormalities a bit more, if that narrows down your differential. So you know the patient is unwell. You've said bilateral and mnemonic changes, and you said hemorrhage. Is that are these your two differentials so far?
Not so typical with hemorrhagic pattern, because this is very dense and more occupying very high location. Mm-hmm. But again, it's not typical with the bat-wing appearance of the pulmonary edema. I feel like if there are two opacities approaching each other, because I can see maybe a bit difference in density at the
What is that difference in density? What is it?
At the peripheral aspect of the lesion. This may be multi-component. Yes.
What is this?
This can be maybe cystic lesion but not typical with fluid level. But the shape.
About this one.
Maybe here multiple cavitations or multiple cystic changes here in the region.
Do you see anything behind the heart?
The window is a bit soft for me, but I can detect maybe multiple opacities in the retrocardiac shadow in the left side.
Okay.
I just need to modify the window, but I can see multiple nodules. I think so. Multiple nodules in the left cardiac shadow, retrocardiac region.
So you have multiple lesions in both lungs. I need a differential and I need next steps.
This may be multifocal pneumonia, may be metastatic nature, but I need to review the history of the patient and approach the patient for the further CT for more evaluation. If the patient has history of TB, previous TB, if the patient has history of previous primary tumor, if the patient
has typical appearance of TB.
Sorry?
Would the patient be in resus if they had TB? Would they be acutely unwell? So let's go to the CT. Let's go to the CT. Yeah.
This is a large lesion. This is with fluid component and cavitation within, with corresponding cavitary lesion in the region of the left lung. The large lesion is that one was discovered in the right hemisthorax in the X-ray. This is cavitary lesions, multiple cavitary lesions. One of the differential diagnoses may be in the context of fluid level within, maybe multiple abscesses, maybe septic emboli with the complication of flaring of the infection, maybe vaginal granulomatosis, However, the typical course of VIGNA doesn't go aggressive like this. The lesion in the right lung is so large. So my differential diagnosis includes multiple abscesses, multiple septic emboli. Maybe the patient has history, not typical with TB, not typical, because fluid levels are seen in many of the lesions.
Okay.
Hydatid cyst may be one, but not typical because I can't see the water lily sign in the regions. Maybe necrotizing pneumonia.
Anything else in the lung, in the CT?
I can see that there is opacity in the left lung. That one that you were scrolling over. I just want to exclude that there is any communication with the abdominal cavity. This can be pleural effusion. This is away from the spleen and the kidney. So this one is pleural effusion.
Mm-hmm.
I just want to detect if there is pleural spilited sign or not. In my opinion, it doesn't pick so much with pleural splitted sign. So this is pleural effusion with multiple cavity lesions in the lung. The initial diagnosis may be multifocal pneumonia, multiple lung abscesses, multiple septic emboli with flaring of inflammation in the lung.
So this large lesion, is this a empyema or is this a lung abscess?
In my opinion, the angle between the lung is acute. I just want to see the coronal to confirm.
Okay.
In my opinion, this keep more with lung abscess.
Okay. And this thing in floating inside it, what is that?
This may be pus component, or maybe rest of necrosis in the parenchyma.
Okay. So you have multiple lung abscesses, bilateral, air fluid level, and thin walled. You didn't mention the wall. And you said there was a pleural effusion, and rightfully so. You said it doesn't look like an empyema. So you consider TB.
All of the lesion is second and irregular.
Okay, so your differential is infection. If this is infection, what else do you want to look for? And you said septic emboli as well. Do you think the patient has a PE? Yes or no?
In the level of the right lower pulmonary artery, I can see filling defect.
Mm-hmm.
I want to trace the rest of the pulmonary vasculature, but I can't detect evidence of septic emboli here in the septic history of embolism in the right lower lung. This right. Okay.
If you had to ask one question about the history of the patient, what would you ask?
Drug abuse.
Yes. So if I say yes, he is a drug abuser, where else do you want to look?
I just want to check the heart to see if there is any endocarditis or septic emboli within the heart.
So would you see endocarditis on a non-gated CT?
I am not accustomed. To be honest, I'm not accustomed to evaluate endocarditis in the CT. But I can see that there is. I can see that there is irregularities in the wall and the septum of the heart. However, I am not.
So, what's the test of choice to look for endocarditis?
I think equal to see the vegetations.
Yes.
And yes.
So yeah, you picked the abnormality straight away, but I think your mind kept going back to TB for some reason again and again. If you don't see the tree in bud, then you need the scarring. If the only way this can be TB is if this was old TB and the patient had dead space and that
I
got
think
secondary
in
infection.
the city, I told I mentioned that the TB is less likely. I think so. In the city.
Yeah. So well done. So there were extra points in there for PE, and then mentioning that this was thin wall and you were not suspicious for cancer, patient history, and you would recommend further, depending on patient symptoms, echo may be helpful to look for any cardiac abnormality. Let's do one more. Have a go at this one. So the patient is a 78-year-old, increasing cough over the last 2 weeks.
Okay, I am presented
Otherwise
with, I am presented with plain X-ray of 72 years old male with cough for the last few days. From the first instant, I can detect that there are multiple opacities seen at the level of the right lung lower zone. Again, just can you modify the window a bit to see the pleural distress? I feel the image is a bit harsh. Anyway, in my routine practice, I will do this. I can see that the left lung shows a degree of opacity in the lower zone. On this window, I can't pick the left hemidiaphragm well. So in my routine practice, I will modify to see if there is a lesion in the lower zone silhouetting the diaphragm, left hemidiaphragm. Pleural distress in the left side is obliterated. Here, the constellation of I can't detect any pneumothorax. I can't detect any corresponding cavities in the upper zones. I can see that there is multiple opacities in the lower aspects of the post lungs. This can be pneumonia. This can be multiple small nodules. In my routine practice, I would like to check for FRCR for previous X-ray to see if the patient has progression of such disease or not. And I would like to communicate the finding with the referring physician and recommend CT.
So you're suspicious for pneumonia?
Pneumonia or multiple nodules in the lower lungs.
Okay. So the patient is well, they only have a cough. What kind of pneumonia do they have?
If the patient doesn't have fever, then it doesn't go well with pneumonia, as pneumonia is cause of constitutional symptoms.
What other kind of process could cause this appearance without giving the patient a fever?
Wegener granulomatous may be one of the causes.
Okay, so Wegener is a term no longer used. It's now called granulomatosis with polyangiitis.
I'm sorry.
Yeah?
Yes.
So in Wegener's, you will see, in the previous one, you were right to think of Wegener's, not in this one. I know vasculitis can pretty much look like anything, but you want a bit more mixed picture. You want nodules and consolidation and a bit of everything going on if you want to think down the vasculitis line. This is more, like you said, it almost looks like pneumonia on both sides. And I think it is a pneumonia of sorts, but what kind? Pneumonia means airspace filling up with something. So it doesn't automatically mean...
Yes.
Yeah.
Yes.
So
this cannot be. This can be a type of interstitial pneumonia, not infective pneumonia. So I can see multiple opacities. Just if you don't mind, ma'am, you can pick on the CT. I just want to zoom it to see. Thank you so much. In this cuts of the CT, I can see that the pattern here keeping with consolidation surrounded with ground glass opacities. So this keeps with halo sign, but not too peripheral. So this can keep with organizing pneumonia. In my routine practice, I would review the history of the patient to see if the patient is a smoker or not. Maybe smoking related disease like cribbled or DI, discriminative interstitial pneumonia. However, the pattern of halo sign is more keeping with organizing pneumonia than the other mentioned causes.
Halo sign or reverse halo sign?
In my opinion, I can see consolidation surrounded areas of density surrounded with GGO.
Yeah. So does that automatically mean halo sign? Does halo would usually used for more nodal looking areas? Yeah, and the solid bit needs to be a bit more rounded and then surrounding ground glass to call it a halo. This is all, like you said, there's consolidation. I agree. There's ground glass. I agree. After that, you need to think about what that consolidation and ground glass is doing. So this ground glass and consolidation is causing something. It's pulling on the lung. All the bronchi are getting dilated.
Yes,
So all the bronchi are surrounded by linear-looking consolidation. And that's called architectural distortion, and it's called traction, bronchial dilatation. So that process is actually starting to scar, and it's starting to pull the lung around it. Infection doesn't do that. Yeah, it can do that, but it's not that symmetrical and bilateral. Organizing pneumonia is a good thought. You're thinking down the right line, but the pattern doesn't fit organizing pneumonia. You want consolidation. You want, like you said, peripheral consolidation, almost triangular looking areas and all that. This is a pneumonitic process. It is an interstitial process. It is caused by something. You went down the right line. You asked me for the history, and then you said history of smoking. So that smoking wouldn't cause, if smoking caused this, nobody would be a smoker. So sadly, smoking doesn't give us. Smoking gives us DIP and RBILD, but this is not the appearance for that. Yes. This is so you would, when you say history, you would say you would give me, when it's a interstitial looking process, you want to ask me more exotic questions like, is there history of travel? Is there history of pets? Is there history of drugs, new drugs? And I would say yes, the patient started in this one, and nitrofurantoin 3 weeks ago. And 2 weeks ago, their cough started. So this is actually a nitrofurantoin lung, and this is starting to fibrose. It's
drug-induced interstitial pneumonia.
Drug-induced, exactly. That's the diagnosis here. Okay, so I think we're running over. So thank you so much. Let's move on to candidate number 3.
I didn't get the feedback of the first case. What was the diagnosis?
It was volvulus.
First
You were
case.
there. Yeah. It was just my mute. Yeah, you were right. But it took a while for you to get the loop right.
Okay. Thank you so much.
Thank you. Do we have candidate number 3 with us?
Yes, ma'am.
Okay. I'm going to give you a chest X-ray again. Okay. This is a routine clinic chest X-ray. A patient who's come in for follow-up.
This is a frontal radiograph of the chest of a mature skeleton. At first instance, I see there's no pneumothorax, pneumomediastinum, or pneumoperitoneum. I see that there are bilateral opacities in the upper zone and mid zone. They are appearing to coalesce, and they are appearing to be more in the periphery. So this pattern is seen in progressive massive fibrosis, as seen in co-workers pneumoconiosis. So I will inquire with the patient about any occupational history and review any previous radiographs if available.
So you said pneumoconiosis because of. Tell me the reasons you've gone down.
Because of the opacities in the bilateral mid and upper mid zones with a pattern of coalescing like conglomerate masses.
Okay, so think you've jumped a bit there. So you're right, there is upper to mid zone. Have you said the word fibrosis yet?
Yes, ma'am. Yeah. Fibrosis.
Yeah, so upper to mid zone fibrosis. So focus on describing that first so you can get all those points. You want to say the hyla are being pulled up and there is linear shadowing, and you're thinking that there is upper zone fibrosis here. Now you're thinking of all the causes that cause upper zone fibrosis. The coalescing, I don't see. You want to see more mass-like areas. You want to see dense consolidations that look like they're coalescing together to go down the PMF, the post-progressive massive fibrosis route. That certainly happens in pneumoconiosis, but I don't think I can convince myself that I see it here. I do see fibrosis, but that's pretty much it. But I do want you to, if I say, have a go at it again and describe how you would describe upper zone fibrosis. Give me all the points that you want to say. Talk about the mediastinum, the diaphragm, the lung volumes, all of that. Try it again.
Okay. This is a frontal radiograph of a mature skeleton. I see that there is fibrosis seen predominantly in the mid and upper zones. There is pulling up of the hilum bilaterally. There is flattening of the diaphragm. So this is a cause of mid and upper zone fibrosis. I'm looking for the causes like sarcoidosis. I'm looking for any hilar lymph nodes. Tuberculosis. I'm looking for any apical opacities. Then another cause is radiation, but there is no pattern of specific pattern of involvement of radiation. Another cause could be ankylosing spondylitis. So I'm looking for any calcification of the interspinous ligaments, which I would like to window for appropriate seeing. And another cause could be drugs. So I will inquire with the patient for any history of drug exposure.
Okay, well done. That was so much better than the first time. So I'm going to give you the CT and see if you can narrow down.
This is a high resolution CT thorax showing the bilateral mid and upper zone fibrotic changes, which are showing honeycombing changes. There's bronchiectasis and honeycombing changes.
So when you want to say the bronchi are dilated in the context of fibrotic lung disease, you don't say bronchiectasis, because when you say bronchiectasis, it means primary bronchiectasis. So you want to say traction bronchial dilatation every time, yeah? So this is upper zone fibrosis with traction bronchial dilatation and honeycombing. Is there something specific about the pattern of fibrosis? Is it more anteriorly or more posteriorly?
It's more posteriorly.
Yeah. Do you know which disease does that?
Not sure.
Okay. Do you want to look at the lymph nodes?
I would like to look at the window, abdominal window, soft tissue window. So there are
not many, but a few calcified lymph nodes.
No significant lymph nodes.
Yeah. So you have a pattern of fibrosis that's quite typical for a disease. This is a posterior pulling of the bronchi. It's almost like somebody standing behind the patient and pulling the lung backwards. It's very typical for stage 4 sarcoidosis. And by stage 4, lymphadenopathy has usually resolved and you have a bit of calcification left. But the pattern of fibrosis, the posterior, this one, is quite typical for sarcoid. And if you see that, the expectation would be to think down the sarcoidosis route pretty quickly. And then the next question will be, what stage of sarcoidosis is this? And then, do you know the stages of sarcoidosis? Can you tell me the stages of etc., which I'm sure you do. So that's that one done. I'm going to move on to the next one. I'm going to try giving you a harder one, see how you do. So this one, don't worry about the diagnosis straight away. Just focus on going about it the right way. So this patient is in looking like they're in heart failure. So you have describe the X-ray for me first.
This is a frontal radiograph of the chest of a patient who is in heart failure. I see that there's no pneumothorax, pneumomediastinum, or pneumoperitoneum. I see there are multiple external leads and midline sternotomy sutures are seen. Then looking at the lung fields, there are prominent vascular markings. There is cardiomegaly, there is unfolded aorta. Looking at the bones are normal. And there is some haziness in the right lower zone, which could be due to effusion, which is tracking along the lateral chest wall. Cardiomegaly.
So, with congestion.
Yes, I think.
Yeah, so it's a typical heart failure chest X-ray. I just wanted to go through it with you to see how you approach a chest X-ray. So when you start with the chest X-ray, take a few seconds, pause about 5-10 seconds to take in all of it, and then have a little paragraph ready before you start. So this one you see straight away there is, a typical heart failure chest X-ray. So when you describe it, just start from the lungs, start from the most obvious abnormality, and then don't start with the pneumothorax, pneumomediastinum bit, because that may be a thing you do in rapids maybe, but not in a VIVA description. Don't start with that straight away. I think it's one trick sometimes we use just to make sure we don't miss a life-threatening abnormality, but saying it doesn't seem as smart as we want ourselves to sound like. So this one is a heart failure patient with a sternotomy. But what this patient has, he has a abnormal echo, and he is deteriorating quite quickly. He has a previous heart surgery for a aortic valve replacement. Let's see if you can spot the abnormality. I'm going to slow it down a little bit. So one thing to remember is somebody gave you a cardiac case, we must be doing well. And I'm going to give you another reformat to see how you do with that. So I told you the patient has a aortic valve replacement, and the patient has an abnormal echo and is in heart failure. You see the heart failure changes with a bit of pleural effusion and some septal thickening. So focus on the heart.
There is left ventricular hypertrophy. Is
The patient would have that anyway if they had aortic valve disease that was subsequently treated. That I'll give you a cardiac mag up view. So look at the aorta. Look at this view. That's one coronary. That's the other coronary. That's the artificial aortic valve. Then there's this thing.
There's an aneurysm arising from the what's this proximal portion of the aorta could be
What is that called?
a sinus of Valsalva aneurysm.
Yeah. Is it an aneurysm or a pseudoaneurysm? First question. And how would you differentiate, if you can, imaging wise? And why do we want you to differentiate? So go down axial this way. You see again that this is the aorta. Then you have this pouch coming off it there. So you would describe that. If you see that, if you pick that, you would say the patient has an aortic valve replacement. There is an irregular appearance to the contour of the aortic sinus. I am suspicious for outpouching. Given the patient's previous history, this may represent, if you're thinking, I want you to think out loud, you're thinking this may represent normal post-operative appearance. I would be interested in looking at patient's previous history. Given the patient's symptoms and aortic valve replacement, I would consider asking the cardiologist to do an echo to look at possible aneurysmal dilatation of the aortic sinus. When somebody has surgery, when somebody has intervention, the kind of aneurysms they get after that are pseudoaneurysms because the wall is deficient. That's the difference between a pseudoaneurysm and an aneurysm. Pseudoaneurysm is quite weak, and aneurysm is quite strong because an aneurysm has all the walls and pseudoaneurysm does not. It is made because part of the wall was deficient, and that's how it was formed in the first instance. So I do apologize. I think it's a difficult case, but I wanted to throw that in so you can be aware you can get cardiac stuff in the exam. Something we don't actually keep in mind all the time. This one you should be able to pick. So this one again, try the style of chest X-ray that we just talked about. Describe it because you can see the abnormality straight away. Now all the marks are in the description.
The endotracheal, this is a frontal radiograph of the chest of mature skeleton. The endotracheal tube is appropriately positioned. I see that there is increased vascular marking seen bilaterally, and there are multiple nodules seen.
Yeah.
So this could represent again cardiac failure.
Nodules in cardiac failure.
No, I think they are vascular markings, prominent vascular markings.
Okay. So if you're saying all of these are end-on vessels and this is just pulmonary congestion, if that was true, why does he have a ETT and why are there no? Why is the heart not enlarged?
So this could be a non-cardiogenic pulmonary edema.
Okay. If what else can it be? You describe them as nodules. Let's stick with that thought. That they are bilateral nodules.
It could be miliary nodules, as in metastasis or due to infectious cause.
Okay.
Or fungal infections also could be.
Yeah. So ask the right questions now.
So I will correlate with if any previous radiographs were available. Also correlate with inflammatory markers.
Ask the examiner the history. You have to ask it before they offer it. Yeah, you would say, rather than say, may I have the history, you can say, I would be interested in knowing the history of the patient. And then you pause.
Mm,
And I would say, immunocompromised.
so this could represent yeah, fungal infection. So pneumocystis carinii pneumonia. Sorry. This could be miliary tuberculosis in an immunocompromised patient.
Mm-hmm. What do you want to do next?
I would like to do a sputum AFP culture to confirm my findings.
I don't have a sputum. Okay.
I will also do an HRCT of the thorax.
Okay.
On this HRCT of the thorax, I see that there are multiple ground glass nodules seen in bilateral lung fields. And some of these are is the central lobular in location.
Mm-hmm.
I do not see any tree in bud nodules, so this could be an endobronchial pathology such as
Such as endobronchial spread of infection.
yes.
You don't see tree in bud?
Cannot. Okay, yes, there are some. Yeah. There are some tree in bud opacities and central lobular also. So this could, in an immunocompromised patient, this supports my diagnosis of Mycobacterium tuberculosis.
Okay. And is that a reportable disease in terms of infection? Do you need to highlight that? Yeah.
I will immediately communicate these findings to this referring clinician, as the patient needs to be isolated till the anti-tubercular treatment is started, as the patient will be communicable in the interim.
Okay, perfect. Let's do one last one.
This is a lateral radiograph of the humerus of a mature skeleton. I see that there is a spiral fracture of the fibula of the femur. The bone, underlying bone, appears normal. I would inquire about the history, whether this was atraumatic, which is most likely
minimal trauma.
So this is a pathological fracture. So I see that there's an underlying abnormality, which is a lytic lesion, which is having a wide zone of transition with the adjacent bone. There is no periosteal reaction. There's no large soft tissue mass. In this age group patient, I would like to know the age of this patient, as my differentials would be dependent on that.
65.
Yes. So at the age of 65, I would first consider a diagnosis of possibility of metastasis. A second possibility could be of of a myeloma. So I will review any previous radiographs to assess. Okay. I would in consultation with the MDT, I would arrange for a biopsy of this lesion, which will be done by the sarcoma team, and follow up with an MRI of this limb, including the upper and lower joints, for assessment of involvement, local staging.
So when you said this could be a metastatic deposit or it could be primary bone, are these your two differential, bone tumor or metastatic tumor? Yeah.
Yes, yeah. Primary could be
primary could be anywhere, or this could be the primary, because it could be a primary bone malignancy. So if this was a if this was a MET, what do you need to request before you go down the biopsy route?
I would do a CT thorax, abdomen, pelvis to scan for the primary, to evaluate for the primary.
Okay.
So there are multiple hepatic target lesions, could be metastasis. Mm. So I'm looking for the cause. A cause could be there's a ectopic. The left kidney is mal-rotated.
Yeah.
The stomach wall is thickened, but it's undistended. The rest of the colon is. I would like to look at the lung windows for any pathology. Okay, the lungs are normal.
The lungs are
lungs are normal. So I would still like to review the intestines, the colon specifically, as the hepatic mets could be.
It's normal.
From there. So then this could be a multi.
Anything else you want to review other than the?
There is a speculated mass in the left mammary region. So a tiny speculated mass. So this could be a primary breast cancer. There is also a collapse of L3, L2 vertebra.
Are you looking at this? I think that's nothing.
No.
It's just breast tissue.
Okay, there's a right mastectomy.
So let's go about it the right way. There's no mastectomy. I think it's just old patient. They're a bit asymmetrical. The breast tissue is normal. We're going to go back to the bone first. So when you see, nobody's going to show you a plain fracture in a VIVA unless there was something special about the fracture management or the location of the fracture. It's a typical, mid bone fracture. It's not going to be a simple fracture. So that's one thing. If you pick the fracture straight away, you immediately need to start thinking about pathological fracture. They're not showing you a fracture. They're showing you something about the fracture they want you to talk about. So describe the fracture. Always say displacement, not displacement, stable, unstable. If that applies, it doesn't really apply here much, but you can say that there are cortical breaches on both sides. And you rightfully said there is a lytic lesion. And straight away you said the bone is normal, and then you said it's abnormal. Like I said, always with the fracture in a VIVA, there's something wrong about the fracture. It's not a simple fracture. Pathological fracture, the minute you pick a pathological fracture anywhere in a skeletal study, you have to say, I want the patient to have a staging CT to look for underlying primary. You have to say that. That's your first step. You have to highlight the X-ray report to the primary physician. You have to recommend a staging CT chest to look for underlying primary. You have to say that very clearly straight away, and that makes you safe. So once you've done the CT, you have to go through the CT in a systemic way, and you have to say it out loud. You're going through. I'm looking for a primary. The lungs appear clear. Because don't be enticed by the clear abnormality you see straight away, because there's so many liver lesions. You want to start talking about them straight away, but I would say, because you see the liver lesions, you should thinking, okay, so it is cancer. I was right. Don't focus on the liver lesions. They're not going to give you a liver lesion only scan. They want you to find the primary, and they want you to have a systemic way of thinking. So when you have liver lesions, but the lungs are normal, you're automatically, rightfully thinking GI tract. So you've said colon. Unless it's a CTC, they're not going to make you look for a very tiny circumferential bowel thickening on a CT. It would be something more obvious. You picked the liver lesion. You did not talk about the necrotic looking nodes that were at the right next to it, and that's one. That's two. And you picked the stomach wall thickening. The minute you picked it, you should have noted that there were nodes next to it. And this patient actually did end up with did have a esophageal primary with adjacent lymphadenopathy and the liver mets. You've picked one bone lesion. You forgot to say that I'm going to look for bone metastasis as well, because nobody's going to die from a pathological arm fracture, but they will get paralyzed from a metastatic spine. So this one here, you should be talking about, or if you can't pick it, you should say it out loud. I would like to exclude further bone metastasis. This one, when you picked, if you had picked it, what would be the next step?
MRI of the spine.
MRI of the spine, yeah, rightful. So What sequence would you like to see?
T2 weighted sagittal.
Okay. There you go. What do you? If this is on your reporting file, what do you want to do?
Yeah, I will immediately communicate these findings to the referring clinician as there is severe compression of the spinal canal, and I see that there is, So this patient needs urgent decompression of this mesh lesion.
Okay. Anything else about the bones? Any other mets you see?
I think the thoracic spine is normal. Cervical spine is also normal.
Okay.
There are modic angular changes at lower lumbar level, but no metastatic changes.
Okay, well done. I'm just looking at the time. I don't want to eat into a candidate 4's time, so thank you. I will move on to candidate number 4, if that's okay. Did you have any questions about any of the cases that you weren't clear about?
No, thank you so much.
Okay, thank you. Candidate number 4, are you with us?
Hello, Dr. Reza. I think you'll recognize
Hi. Yes, I do. Yeah, I will give you a case. Let me bring it up. Can you see the screen? Okay, have a go.
I am presented with a frontal radiograph of the chest. There are bilateral opacities with their large margin towards the pleura, particularly in the right upper and lower zone. They have obtuse margins with the pleural edge. In the left mid-zone, although the opacity has a ill-defined border, particularly superiorly, I think it's pleural-based as well, because it has sort of a incomplete or ill-defined margin in one of the sides. So I'm looking to see if there's any destructive bone changes. There are none. There's no pleural effusions. There's no other abnormality, or there's no hilar lymphadenopathy, and I do not see any other focal mass lesions in the lung parenchyma. So in summary, there is abnormal, I suspect, soft tissue thickening, likely malignant within the pleura. I am suspecting a pleural mesothelioma. I would like to review the patient's history, correlate with previous imaging, and request a CT, thorax, abdomen, and pelvis.
Okay. So you mentioned, I'm guessing these two, and the one in the left mid zone.
And there's a right paramediastinal as well. Apologies as well. Superior mediastinum, yeah.
Okay. So you said no bone destruction. Do you want to think about that again and help me find the bone?
Yes, the second rib is missing. So I suspect that there is destructive bone changes. Also in the left mid-zone, there is an absence of the rib there, suspicious of bony invasion. So this further reaffirms my diagnosis of a sinister process of malignant pathology, likely mesothelioma, being the most common cause.
Why the interest in mesothelioma? If I say the patient has no asbestos exposure and they are 35 years old?
Well, the reason is when it goes into the medial part of the mediastinum, the paramediastinal lesion and the lobulated appearance with the destructive bone changes, that would be my primary differential. However, this can also be a primary bone tumor that is invading the bones. And in that case, that there would be a wide range of differentials for that, depending on the patient's age. So yes, this could be a primary bone tumor as well. I don't think it's an infectious cause, and I'm not suspecting any other non-sinister pathology in this instance. Less likely.
Primary bone.
It can also be metastatic to the point of apologies.
So they're bilateral. So at least one would be, if they were primary, you're saying one primary bone tumor that was metastasizing to different ribs?
Possibly, or it could be a malignancy elsewhere that has metastasized to the ribs. And actually, looking at the I'm just trying to see if there's any other abnormality that I can spot. Okay, so looking at the CT scan, there are multiple destructive bones, soft tissue densities based in the rib cage with destruction of the adjacent bone, and they're more apparent. I can also see a right paraspinal mass. In the left kidney, there is a enhancing mass, and I would like to review it better. Yeah. So there is an enhancing mass, and it has sort of a central enhancement. I'm suspecting an RCC in this instance. Normally, I would look to see if there's any adjacent lymph nodes, and I would check to see if there's involvement of gerotis fascia, as that would change the classification. I would look for other lesions, and I would interrogate this in a coronal view. And apart from that, if I'm only given this and there's no abdominal imaging, this is as far as I can take this image.
Okay, so what about so you're suspecting an RCC with bone metastasis, I'm guessing?
Yes.
So what are the what is the typical word I want you to say when you're talking about RCC?
Lytic bone mets. Lytic bone mets, is that what you want? And hypervascular metastases as well.
So hypervascular is more when they're in the organs. So for example, if there's a lung met from RCC and you try to biopsy, they tend to bleed a lot. But if it's in the bone, the typical appearance is an expensile met. So if you think of the organs that can give you expensile bone metastasis, do you have a list for me? One or two?
The malignancies that can give expensile bone metastasis?
Expensile bone mets, yeah.
Could it also be thyroid malignancies and potentially breast as well, but I'm not quite sure, to be honest.
Okay. So what would you do next?
So next, I would request a CT abdomen and pelvis. I would refer this patient to the urology team. With the CT abdomen and pelvis, I would probably like to do a triple phase scan, so a urogram, just to assess the renal tract and exclude involvement. Refer to the MDT urology review, and potentially a biopsy could be taken, and potentially from one of the soft tissue lesions in the bones.
Any other imaging you want doing?
I would also consider a PET scan just to look for any other lesions.
Anything else to make sure the patient is walking next week?
Oh yes, I'll check the bones and check the spine. So I'd look at the sagittal imaging as well. Is that yeah? And also here I can see that the spinal cord is involved with the soft tissue mass, and there's invasion of the fecal sac and complete soft tissue opacification of where I would expect the spinal cord to be. I would be very worried about spinal cord involvement, and I would contact the orthopedic team, alert them about this patient, and then follow up with further imaging, potentially an MRI, to assess the spinal cord.
Okay, well done. Let's move on to the second one. I think you got everything right. The description I wanted straight away was multiple bony lesions, because I think in this one it's quite obvious the bone is missing here, and that's why they look so clean. That's why you pick them straight away, because there's no bone behind it. The description was, if this was the only abnormality, I would buy the pleural-based obtuse margin, etc. But here the bone destruction, and here it's quite clear. So I was looking for bilateral aggressive lesions causing bone destruction. I'm concerned for underlying malignancy, metastatic or primary bone, or whatever you wanted to. But after that, I think the CT obviously caught up very quickly. In terms of safety, the RCC was right at the edge of the chest, so that was the one completing it all. Expensile bone met with a left renal lesion suggestive for renal cell primary. and you have to always think of the spine, because you always want to not miss the thing that keeps the patient safe. Don't want to make a mistake like that and get everything right and miss the spine bit.
Yeah.
Because that makes it hard to then give you high score or otherwise a case. Very well done. I will give you a harder one.
Oh no.
Okay. So this is, let's see without history. Then I'll give you the history if you ask for it.
Okay, I am presented with a frontal radiograph of the chest. There is no obvious abnormality that is apparent to me. However, I do notice that there is increased reticular nodular opacity in the periphery of the lungs bilaterally, and there is also I forgot the name for it. The line for long-term portocath in situ. In the presence of the portocath in situ, I'm thinking about patients that need long-term medications, administration of IV medication. So looking at the lungs, I can actually appreciate bilateral tram-like and cystic bone changes, most pronounced in the upper and mid zone. In the right periphery of the right mid-zone, I can appreciate a focal opacity with central lucency, and I wonder whether that could be a cavitating lesion. I'm also looking at the lungs to see if there's any further opacities, and I suspect that there may be an opacity in the right lower zone, just behind one of the ribs, the lower ribs. Looking at the left lungs, there's no further changes. There's no hilar lymphadenopathy, no pleural effusions, and no bony abnormalities that I can appreciate. In summary, this is a patient who has a post-portocath with bilateral cystic bronchiectasis and a focal opacity in the right mid-zone peripherally, and a suspected further opacity in the right lower zone. I would think about cystic fibrosis in the first instance, and with the cavitating opacity, that I would be worried about atypical infections. I know that cystic fibrosis patients are prone to ABPA, and they're prone to aspergillomas, and they're just prone to normal sort of bronchiectasis and infections associated with that. So I would like a CT scan to further characterize.
Okay.
I'll just wait until, if that's okay. Okay. So axial plain CT scan of the chest, bilateral cystic, so bilateral traction bronchiectasis with cystic bronchiectasis, most pronounced in the right mid-zone, where there is also associated patchy opacities that have the appearance of tree bud nodularities. And there was also one of the cystic bronchiectasis, actually both bilaterally, there's endobronchial thickening and further thickening around the cystic, atypical infections in these patients.
What is endobronchial thickening?
Endobronchial thickening is...
you mean bronchial wall thickening?
Bronchial wall thickening, yes. Sorry.
Mm-hmm. And you mentioned traction, bronchial dilatation, and bronchiectasis.
Yes.
So you have to pick one, I'm afraid.
Yes, you're right. I think, sorry, there's cylindrical and cystic bronchiectasis.
Yeah, exactly. Yeah.
Apologies.
So when you say traction, you're implying ILD, and the patient
Yes.
doesn't have ILD. Yeah. So yeah, I think, and I think you picked this tiny lesion as well on the radiograph, which was good. Yeah, bang on. I think the portacath is a hint, but you can't say I got the case because there's a portacath. You have to be a bit more. It's a subtle hint. So you can't bank the diagnosis on the fact the patient has a portacath. You can say it later on, but don't let it be the reason you say cystic fibrosis. Although that's why we all do it, but let's make it not that obvious.
Yes.
I will give you another one. Wrong one. Okay, 1 second. Okay. Yeah. Okay. Shortness of breath.
I am presented with a frontal radiograph of the chest. Although this is an AP erect film, I think the patient does have a degree of cardiomegaly. There are bilateral reticular opacities or interstitial opacities, and I can appreciate curly B lines, most pronounced in the right mid-zone. I think there is also a degree of upper lobe diversion. There's no pleural effusions. I'm looking to see if, so there are features here in keeping with pulmonary edema, but I would like to see if there's any other abnormality.
Okay, so the patient doesn't have any other abnormality on the X-ray, but they are a known heart failure patient, and they are now septic. With rigors.
Okay.
Yeah. So I'll show you the CT file.
Okay. Right. Okay. So bilateral. Sorry, I'll just have a better look at that. Okay. Can I just see the left main pulmonary artery as well? I just want to see if there's.
It doesn't go high enough. It's a cardiac CT.
That's all right. Okay. So there are, so left pulmonary artery demonstrates a central filling defect in keeping with an acute pulmonary thromboembolism. There are wedge-shaped bilateral posterior basal consolidative and ground glass changes with areas that have sort of interlobular septal thickening. These are in keeping with pulmonary infarcts in the presence of pulmonary embolism. I also noticed that in the left kidney, there was a wedge-shaped area of hypoattenuation that is extending to the renal cortex. I cannot appreciate a cortical rim sign. I would interrogate the left renal artery in detail to exclude a filling defect. However, this appearance to me is suspicious for a left renal infarct. So in summary, there are multiple, so there are pulmonary and renal infarcts. And in a patient with heart failure, I would be worried about thromboembolic causes, such as atrial fibrillation or an irregular heart rhythm. It is I would interrogate the heart to just exclude, atrial septal defects or any other abnormality, but I can't appreciate that. And I think there is also a filling defect in the left ventricle, which I suspect is most likely a thrombus, just because this will be the most common etiology. Having said that, I would like to interrogate it and assess its attachment to the, if there's any attachment to the adjacent muscles, which I cannot appreciate any attachments. So this is likely a thrombus in the left ventricle as well.
Mm-hmm. So what are the infarcts then?
So could the infarcts be this thrombus is throwing off microemboli and causing infarcts?
So what are you concerned about in the patient's history?
So I would be concerned about a possible etiology. So what is causing the thrombosis? So what causes of thrombogenesis or having an increased risk of thrombus? So atrial fibrillation would be one. Is there a myocardial infarction or an aneurysm secondary to previous infarct? And actually looking at the cardiac wall, is there some thinning of the, I could be overcalling here.
It's dilatation because he's in heart failure. It's just a dilated LV. But in terms of history, are you concerned about any underlying drug history, or what do you think now?
I'm thinking about. So first, I would review the patient's biochemical markers if they're available to me, and just check that he's not in a hypercoagulable state. Other things that I would think about would be medication that would cause thrombogenesis. Is that what you're hinting at? I'm not actually. I haven't picked it up.
That's you digging a hole.
Okay.
Can you think of a medicine that gives you thrombus in the heart? I'm talking about drug abuse. Okay, last one. Have a go. We have 4 minutes. I think we can squeeze this in.
Okay. This is the last one? Okay.
Yeah.
I thought it was the one I saw previously.
No, this is in, so I want to see if you got the,
right. Okay. So I am presented with a frontal radiograph of the chest. There is a right peripheral opacity abutting the right chest wall with an obtuse margin to the chest wall and some pleural thickening in that region. I suspect that this is a pleural-based mass. I can't see any underlying destructive bone changes, but because I can see underlying pleural thickening, I am looking to see for signs of previous asbestos exposure. And actually in the left lower zone, there is an irregular opacity that could be a holly leaf sign in the left lower zone, which might represent. I would normally window to look at the hemidiaphragms to see if there's any pleural plaques in that region. Elsewhere, I can't appreciate any hilar lymphadenopathy. And there's mild blunting of bilateral costophrenic angles, which might represent a small pleural effusion. So in summary, I have a pleural-based mass with bilateral calcified pleural plaques. My primary differential in this instance would be a mesothelioma, but I would like to correlate to previous imaging, as I also know that there is one other differential for a benign pleural-based mass, such as a pleural fibroma. So if I can have a CT, it would allow me to better interrogate this lesion.
So on the X-ray at one patient ago, what was the mistake you made?
I immediately didn't recognize that the mass could have another differential, that it had obtuse margins.
You didn't pick the bone destruction?
Yeah, I didn't pick. Is there bone destruction here?
Where is this rib?
Yes. Okay, that one would have been a bit advanced.
So this, the minute you see an obtuse, you want to either call it cancer or not cancer. For that reason alone, you need to stare at the rib really closely, over and under a lesion. Whenever it's peripheral, the margins are quite obtuse. Like you said, they're well defined, so it's clearly not in the lung. It's either in the pleura or it's in the chest wall or outside. you have to pick up the bone destruction. It changes it completely. And this is it's not subtle. It's very clear. And this was 5 minutes ago. A repeat of the same thing. And I'm glad I checked you. You made the same mistake again.
Yes.
You have to pick the bone destruction. If you pick the lesion.
Yes. I could not appreciate that, but I will look into practicing it.
So let's see if you say the right words to describe it.
Yes. So in the right chest wall or the right ribs, there is a soft tissue mass that is expanding the ribs, which is suspicious for an expansile bone mass. It also has some peripheral areas of calcification, but I think that's residual rib. I would look at the other chest. I would look at the other bony structures to see if there's any further lesions. Particularly, I would interrogate the spine to exclude any spinal compression or pathological fractures.
There's nothing else wrong with the patient. It's only this isolated abnormality.
So in this instance, I would look at the lung windows. I would interrogate the hilum and to look for a primary in my immediate imaging. And then I would do a CT abdomen and pelvis with contrast. And I would, then in that case, if everything has been excluded and there's no other primary found, I would think about a primary bone tumor. And in this age group, I'm sorry?
For example,
in this age group, because I think this is an elderly patient, just looking at the chest X-ray. So I would think of myeloma as the second most common differential, a plasmacytoma/plasmacytoma if it was a solitary lesion, and I think it is because we've just said there's nothing else. And so in that case, I would refer to the relevant MDT, and I would biopsy the lesion.
Yeah, this is biopsy proven plasmacytoma. So, okay, well done. But the take home message for you is you have to pick the bone, because that's what decides malignant versus when the margins are this smooth, it could very well be a benign lesion. It could have been there 10 years ago. But if you pick that bone destruction, you can very quickly get out of the X-ray, escalate, and move on to the next case. But yeah, well done.
Thank you.
I think we're right on time. Thank you, everyone. Does anyone have any questions about these last 4 cases?
So the chat is open. Any questions, please ask freely now. This is the time.
Can I have a go at the questions now? Do you want
Yes,
to?
please. Yes, please.
I have a question.
Take your time, whatever suits you.
Okay, the first question is, I have a question about the military TB case. On the CT, there was a mention about tree and bud, but the diagnosis was military. I think the word is miliary, and you're writing military, so that's one thing to correct. We have to call it miliary TB. Miliary TB is, like you said, hematological spread. The patient does, when somebody is immunocompromised, they have a bit of everything going on, and this patient was actually reacting to a drug as well. So this was a mixed diagnosis of hypersensitivity with superadded atypical infection. But in miliary TB, you should not have tree and bud. In endobronchial spread of TB, you have tree and bud and all these nodules. When you have central lobular nodules, that implies that there's something inside the airways. That's if that was TB, it wasn't miliary, it was endobronchial spread of TB. Is the lower right vasculature on this chest X-ray normal? Yes, it is normal. This one on the screen right now, this is normal. With age, you get this sort of blunting of the diaphragms bilaterally quite commonly. But like the last candidate said quite rightfully, you have to say, it could represent small pleural effusion, but this is just common pleural thickening in elderly patients. This right lower lobe vessel can look quite prominent in many people, but this is normal. If you are concerned that it looks prominent, you try to follow it. If it's something linear, the likelihood of that being a vessel is more, and then you follow it back to the hilum and think what lesion can look like that. I can't think of a lesion that looks linear like that is coming out of the hilum towards the base, which can only be a vessel. Isn't myeloma plasmacytoma a purely lytic lesion? Why does it appear soft tissue density in the final case? A lytic lesion is something that destroys the bone. When bone is destroyed, it doesn't result in air or fat. It looks like soft tissue. So it doesn't calcify, it's just the bone expands and it can look like soft tissue. Miliary can be ground glass. Yes, it can be. How to differentiate between collapse and consolidation? That's a good question. Usually they both happen at the same time. So that's one way to get out of a tricky spot. If you can't make up your mind, something has to have consolidated before it collapsed. So it's quite common to see in reports there is collapse consolidation. Collapse doesn't always mean there is something wrong with that part of the lung. Collapse can be secondary to something proximal to the lung. Collapse just means that part of the lung deflated. So collapse has to cause volume loss. That part of the lung has to get smaller. Consolidation alone is replacement of the air spaces with something else. It could be blood, it could be pus, it could be blood, water, or inhaling something, or a reaction, exudative collection inside the air spaces. So consolidation means normal lung volume replaced, air is replaced by something else. Over time, that part of the lung gets so underventilated that it starts collapsing. The body starts pushing air into it and just gives it a lower volume and it collapses. So the way to differentiate on X-ray is you want the fissures to move. The fissures have to go towards that area of abnormality, and that means collapse. Sometimes in consolidation, you can have increased volume as well, and that's a very typical sign of a certain infection. I don't know if you guys remember it or not, but when you say consolidation that is causing increased volume or bulging of the fissures, that's a typical sign for Klebsiella pneumonia. So that may be something you get asked, is a consolidation that has a mass effect or is pushing the fissure. You have to think of cancer, and if it's an infection, it would be Klebsiella. So I hope that answers your question. Would you consider brown tumors if old and plus fibrous? Yeah, you would. But that's a discussion for the VIVA. Common things commonly is myeloma more common. Fibrous dysplasia, you tend to get asked for more for pelvic bones, or it's a more heterogeneous appearance. But obviously, anything can look like anything. On this last case, why could this not? I can't keep track of the chat. It's moving too quickly. For the sarcoidosis case, silicosis in cold worker can also cause lymph node calcification. Was it the posterior predominance that made sarcoidosis more likely? Yes, absolutely. It was a typical appearance. In cold workers, pneumoconiosis, you tend to get lung calcification as well. There's something sarcoidosis does not tend to do. The nodules you get in pulmonary sarcoidosis, they don't tend to calcify. Whereas in cold workers, you tend to get lung nodule calcification as well. And the lung is a bit more rough looking, dirty looking, scarred looking. What management can we suggest for end stage sarcoidosis? Nothing. It's irreversible. And those patients are usually under follow-up. Sometimes they tend to get a flare. So somebody with stage 4 sarcoidosis can have a flare and they can develop parenchymal or the nodules again. And that's when they need treatment. But purely fibrotic sarcoidosis does not have a treatment. Posterior lung fibrosis, why not post-respiratory distress syndrome? Because it wouldn't be upper lobes. Post-ARDS, lung tends to be posterior. Yes, you're correct, but they don't tend to favor the apices. It doesn't go that high. Ma'am, can we have one time? Of course you can. It's up to Dr. Sami to invite me back. I'm happy to come back. Post-lung fibrosis, why not TB? It can be TB. In TB, when you get fibrosis like that, the lung has cavitation. The lung has a lot more asymmetrical scarring. You get bronchiectasis, you get scarring and cavitation. So I can show you a case next time for TB to put it side by side so you can appreciate it. But yes, purely on X-ray, yes, you can talk about TB. But when it comes to that CT, you should think of sarcoidosis only. On this last case, why could this not be a pleural met with rib destruction? It absolutely can be, absolutely. And if I was the candidate, I would have said pleural met with rib destruction or a bone met, vice versa. It definitely can be. You cannot differentiate purely on X-ray. But the take-home message should be that if you see that on a chest X-ray, you have to pick the bone destruction and you have to call it cancer. You have to escalate appropriately, considering the patient likely has cancer, either primary or metastatic. So it doesn't matter whether you call it pleural or bone. You can't differentiate on X-ray. Can't see any more questions. Sigmoid or cecal. Go back. I've anonymized the cases now. I can't find them. Can't find the case for some reason. What are the differential for expensile meds? I think the last candidate answered that quite well. She said renal, thyroid, breast can cause pretty much anything. Breast is the only primary that can give you sclerotic and lytic bone metastasis. So if in doubt, breast can pretty much cause any kind of bone mets. But the differential the last candidate gave was pretty accurate for expensile bone mets. Please tell me how to differentiate interstitial lung disease from lung pneumonia. That's probably a lecture rather than a 2-sentence answer in terms of differentiating interstitial lung disease from pneumonia. But the simple answer is consolidation. You want to see haziness and on a bigger scale and consolidation to call something pneumonia. Interstitial lung disease needs to give you a reticulation that gives you lower lung volumes. You need to see reduced lung volumes to go down the ILD route. If you have haziness, general haziness, you need to talk about pneumonia, or if in doubt, pneumonitis is a good word, because pneumonitis doesn't really commit to infection or idiopathic process. Because in the beginning, ILD, like drug-induced or something, can look like pneumonia. So pneumonitis is a good word to get out of that situation. But differentiating ILD from pneumonia is a long conversation that we can probably pick up another time. That's okay. Okay, thank you.
That is just a comment. So thank you very much. You can hear me. Some of you can hear
Yes,
me.
I can.
So
Yes.
fantastic session. Thank you very much. And you have already promised them a session. So we will, of course,